Welcome to the ASPEN video series on medications via enteral feeding tubes. This video series is a collaboration between the American Society for Parenteral and Enteral Nutrition and the University of Rochester Medical Center. This video series was developed by ASPEN workgroup members listed on this slide. This is video 3, Medication Order Review, Preparation, and Dispensing for Feeding Tube Administration. My name is Lingtak Neander Chan, and with me is Dr. Stephen Rappaport. There are 5 learning objectives for this video: to explain the medication order review process, to assess whether the medication prescribed is indicated and properly dosed and formulated for feeding tube administration, to determine whether a medication is safe for feeding tube route, whether it is gastric or small bowel, based on volume, osmolality, pH environment, and excipients, to describe the types of feeding tubes that may be used for medication administration, and to explain how to prepare and dispense medications that will be delivered via a feeding tube. The 5 rights of safe medication administration are fundamental principles designed to ensure the correct and safe delivery of medications to patients. These rights focus on giving the right medication at the right dose to the right patient through the right route and at the right time, helping to minimize errors and improve patient safety in healthcare settings. Reviewing orders for medications to be administered via feeding tube. Use electronic health record or EHR to guide practice, which prompts for route when enteral medications prescribed, prompts for access site when enteral tube selected, restricts being able to order medications or formulations which are contraindicated for tube administration, and ordering tube placement can be used to trigger alerts. The complete prescriber order should also include instructions for feeding tube administration of each medication. Ideally, the prescriber has coordinated the method and feasibility of drug administration with the nurse and the pharmacist. The order should include dose, form, for example, tablet, liquid, suspension, capsules, or packets, frequency, and route, such as gastric or jejunal. Instructions for crushing, opening capsules, amount of purified water for dilution, additional pertinent delivery instructions, for example, duration of tube feeding hold, and a minimum of 15 milliliter of purified water flush before and after medication administration. Flush volumes for pediatric patients will be less. Changing to a route of administration that is inconsistent with an existing drug order can be challenging because of liability concerns, aspiration complications. Sometimes patients get medications orally when awake, but via the tube when asleep, which further complicates things. Also, prescribers may default to an oral route and don't even consider other routes for drug administration, especially in fluid-restricted patients. Water flush volumes need to be specified, or they may be simply not happen. Review allergy sensitivity history of patients. Medications are formulated with active drug ingredients or active pharmaceutical ingredients, and inactive additives. Inactive additives may include dyes, fillers, bulking agents such as in lactulose, suspending agents, preservatives, sweeteners, flavorings, and alcohols. Some additives may be contraindicated for certain patients' diagnosis or treatment plan, such as ketogenic diet, celiac disease, diabetes, or short bowel syndrome. Consider the following factors to determine the appropriateness of medication indication, dose, and form for feeding tube administration. First, indication. What is the purpose of the medication, and does it make sense for this patient? Dose. Is the dose appropriate for this patient based on the indication or indications, including age, weight, or other variables? Form considerations. Not all conventionally manufactured medications, such as tablets, capsules, or liquids, may be simply crushed, opened, or further diluted because this manipulation may alter the action of the medication. This, in turn, increases the tube clogging risk or produce aerosolized particles that may be teratogenic or trigger allergic reactions. Volume. Volume of water needed to dilute a medication may be prohibitive for those with fluid restriction or for small bowel delivery. Osmolality. Liquid medications with greater than 600 milliosmol per kilo may delay gastric emptying and can cause gastrointestinal discomfort, cramping, and diarrhea in the small bowel where there is no extra fluid available for dilution. pH environment. Some medications require gastric pH for optimal dissolution or activation. The following are additional factors for pharmacists to consider when evaluating medication orders for medications down feeding tubes. Tablets that are not adequately crushed and dissolved in purified water. Tablets that are crushed and dispersed in purified water but may settle out requires shaking just prior to administration. Film-coated tablets are also more prone to clogs as the coating does not always dissolve adequately. High amounts of insoluble excipients in large tablets, such as cellulose, consider the physical size of the dosage form in comparison to the dose. Chewable tablets. While they can be given via feeding tubes, they often include gums to improve delivery when chewing, which can clog feeding tubes. Capsules with beads. Some beads inside the capsules may contribute to tube clogging. Highly viscous liquids and suspensions. Typically, they need to be diluted further, at least in a 1-to-1 ratio with purified water. Poor solubility of the active pharmaceutical ingredients. The slurry of a crushed but insoluble mixture increases tube clogging risk. For example, magnesium oxide tablets can be crushed, but they are not soluble in water. Ensure proper form of medications being ordered. Ensure the medication being ordered is the appropriate form for feeding tube administration by the intended routes. Beware of the exact type of tube and tip location for the individual for whom the drug is being prescribed. Feeding tubes with smaller French sizes and longer lengths associated with higher risk of tube clogging. This may include nasally inserted tubes and jejunal tubes. If the patient has a gastrojejunal feeding tube or GJ tube, specify whether the medication is to be administered via the gastric port or G port or the jejunal port, the J port. Generally speaking, the gastric route or the G port is the preferred port for medication delivery if it is safe to do so. For those not familiar with enteral access, there are short-term and long-term feeding tubes. Nasogastric or oral gastric tubes, NG or OG, for gastric feeding. Nasoenteral tubes for small bowel feeding, also called nasoduodenal or nasojejunal feeding tubes. They're typically used for up to 6 weeks, range from 3.5 to 16 French sizes. They can be inserted at the bedside using blind insertion or aided with various direct or indirect instruments to improve safe passage. Other techniques used include endoscopy or fluoroscopy. Gastrostomy tube, G-tube. for gastric feeding or decompression, drainage. They can be standard long-length tubes or low-profile skin-level devices. The range is from 12 to 30 French sizes. They can be inserted via endoscopy, surgically, or interventional radiology. Internal retention device can be a water-filled balloon or a non-balloon plastic dome. Gastrojejunostomy tube, GJ tube, for various uses. They can be standard long-length tube or low-profile skin-level devices. Typically contain two lumens, one to stomach and one to jejunum. Gastric port or the G port is typically used for drainage or decompression, and the jejunal port or the J port is for feeding to lower aspiration risk. They range typically from 6 to 30 French sizes. They can be inserted via endoscopy, surgically, or interventional radiology. Medications should ideally be given through the G port or the gastric port when possible. If the G port is used for drainage, it must be clamped afterwards for a period of time to facilitate medication passage into the small bowel. Long-term enteral access. Jejunostomy tube or J-tube for small bowel feeding. Can be standard long-length tubes or low-profile skin-level devices. Range from 12 to 24 French sizes. They can be inserted via endoscopy, surgically, or interventional radiology. Due to the small diameter and the risk of clogging the tube, liquid medications are highly preferred for administration with this kind of tube. If high osmolality medication is ordered via the J tube, it needs to be diluted to prevent cramping or hyperosmolar diarrhea.
Moving on to some general issues in medication preparation and administration. Prepare and administer medications separately to avoid drug-drug incompatibilities that can interfere with the intended therapeutic response or form precipitates that can cause tube clogging. Use end-fit connections to prevent wrong route administration. Do not mix medications with feeding formulas to prevent drug-nutrient interactions and to ensure the full medication dose is being delivered to the patient with the intended therapeutic response at the correct time. Give water flush before, between, and after medications are administered. Then restart feeding, unless the feeding needs to be held for a period of time per medication guidelines. Hold or stop tube feedings during medication delivery. Some medications require that tube feedings be held for a period of time before and after medication delivery, for example 1 to 2 hours before and after, to improve drug bioavailability. Consult a pharmacist or medication resource for guidance on holding tube feedings. If tube feedings are interrupted for extended periods, it may be necessary to adjust the rate, volume, or schedule to ensure that the patient's daily nutritional needs are met. A dietary consult may be helpful. If holding tube feeding for extended periods, make sure to document it in the designated area of the health record, medication administration record, and/or intake flow sheet. Document the exact amount of tube formula given so that the entire healthcare team is aware of the nutritional therapies that have been administered, held, or not given within the 24-hour period. In addition to the list of references at the end of this video, some other online resources and databases should be kept in mind. Be on alert for film coating, as it may not be immediately apparent that the drug has a coating. Film-coated tablets may increase the risk of clogging the tube. If ordered, tablets need to be completely crushed and dispersed sufficiently with an adequate amount of purified water just prior to administration, followed by thorough flushing. Medications that are modified release, for example delayed release or enteric-coated, extended release, or sustained release, are not to be crushed, because crushing may result in release of excessive doses and produce drug toxicities, variable serum concentrations, and potentially severe adverse effects, including fatalities. However, some modified release capsules that contain enteric-coated granules are approved for feeding tube delivery when dispersed in a pH-adjusted liquid. For example, some medications require acidic liquid to prevent granules from sticking together for gastric delivery. Some medications may require bicarbonate to dissolve enteric coating for small bowel delivery. Direct visualization is always recommended prior to administration, as granule size may be a limiting factor. A dosing change may impact the size of these granules. Medications available in liquid form or suspensions are frequently formulated with sorbitol or other sweeteners and flavoring agents, making them palatable for oral use, but may result in a high osmolality. Liquid medications with an osmolality greater than 600 may delay gastric emptying and cause GI discomfort, cramping, and diarrhea. Liquid medications may also include thickening agents, increasing viscosity and raising the tube clogging risk. Diluting them at least 1:1 with purified water may lessen GI side effects and tube clogging risk. Some medications may cause harm to the person crushing it due to hazardous exposure of aerosolized particles that may be teratogenic or allergenic. Closed systems are required for safe preparation, along with appropriate PPE, gown, mask, and gloves. As therapy is ongoing, perform ongoing medication review with the patient and/or caregiver to determine correct route, medication tolerance, therapeutic effect, ease of preparation, correct administration, and ease of feeding tube delivery, as well as issues with tube clogging. Assess whether the medication can be taken orally if patient swallow is improved, or by another form if there are issues identified. Inform the pharmacy of any changes to the form or route of administration and reorder the medication accordingly. It's important to maintain a list of the medications commonly used in practice with proper administration instructions via gastric and jejunal feeding tubes, and to make that available to all team members. A medication template or medication order set can be created in the electronic record for frequently ordered medications that includes route with proper preparation and administration instructions.
My name is Susan Hughes. I'm a pharmacist at the University of Rochester Medical Center, Strong Memorial Hospital in Rochester, New York. My current role is as Assistant Director of Pharmacy for Compounding Services, working with all of our pharmacy sites throughout our hospital system. Medication compounding versus preparation and administration. Preparation of a single dose of medication for a single patient when administration will begin within 4 hours is not considered compounding, but is administration. This includes crushing a tablet, opening a capsule to mix with liquids, or reconstitution of a conventionally manufactured product for feeding tube administration. Compounded medications. Medications that are modified from one dosage form to another to enable alternative administration or improve tolerance. This should never be the first option. For optimal patient safety, commercially manufactured pharmaceuticals should always be used whenever feasible. When no other alternatives exist, pharmacy compounding by appropriately trained staff can be used to tailor therapy to the specific needs of an individual patient. This video shows the compounding of a bottle containing multiple doses of an oral suspension made from medication tablet drug source. First, the pharmacist rinses and calibrates the final container to assure accurate final volume. Next, she verifies the formula already on file, selects the correct tablet drug source, counts the required number of tablets to use, and gathers other components required for the formulation. In a powder enclosure hood, the pharmacist uses a mortar and pestle to crush the tablet source into consistent small size, allowing for better dissolution and more consistent suspension of the medication in the finished preparation. Careful and complete transfer of all the required medication into the preparation is accomplished with rinsing the mortar and pestle with the final vehicle into the final container to assure accurate concentration of the compounded suspension. The final volume is then adjusted with additional vehicle to match the calibration marks determined earlier. The bottle is then labeled with patient information and instructions for use and storage. In many healthcare facilities, individual doses of all medications, sometimes generally called unit dose packaging, are dispensed to inpatients during their stay. In this video, a technician is preparing a single dose for a specific patient from a bulk bottle of compounded oral suspension. Shaking well for about 15 seconds prior to withdrawing the dose is important to ensure even redistribution of the active drug throughout the source bottle. Accurate measurement of the required volume is critical. Here, an oral syringe with an NSAID safety tip is used to package the single dose. The NSAID safety tip only attaches to a feeding tube with an NSAID connector, preventing wrong route administration. The individual dose is labeled with the specific patient's information and details about the medication, storage, and stability. Barcoding may also be used during compounding to confirm components, as well as on this label. The pharmacist's final check prior to dispensing to assure correct source bottles were used to prepare individual doses, and during administration to assure the right dose of the right drug is administered to the right patient at the right time, and by what caregiver. The pharmacy technician leaves the source container and the prepared dose for final check by a pharmacist prior to dispensing to patient caregiver on a patient unit. Some hospital pharmacies use sophisticated packaging machines to repackage high-use medications they cannot purchase already in single-dose, unit-dose packaging from the drug manufacturer. In this video, this machine can repackage oral solids like capsules or tablets, as well as liquids, commercial or compounded by the pharmacy, into USP-compliant packaging to assure optimal shelf life. The technician has set up the machine to repackage oral tablets, and after careful checking and double-checking labels and components, he is feeding the tablets into the machine. The machine forms the packaging uniquely for each product and also generates labeling with barcoding for safe medication administration. When the liquid is repackaged, a peristaltic repeater pump is used to accurately deliver the required volume into the package's cup, and the machine seals and labels each dose automatically. Quality assurance testing of completed batches checks for accurate volume delivery of these repackaged liquids.
And here are the references for this video. This video series was provided to you by ASPEN in collaboration with the University of Rochester Medical Center and supported by Cardinal Health.